Welcome to the wrap-up interview session of the TCTAP 2023. Today, we will wrap up the transcatheter and mitral valve intervention. And now, the mitral and tricuspid therapeutics, transcatheter therapeutics rapidly evolving. However, there are few experts that takes a bird's eye view on this field that I can count on my fingers. But we have three invited amazing faculties about the mitral and tricuspid therapeutics. First, that's Samir Kapadia from the Cleveland Clinic, a master of the transcatheter, mitral and transcatheter, tricuspid therapeutics, and Dr. Shih-Hsien from the Taiwan, the National Yangming University, and he's a very, very expert and master of the transcatheter H2H repair. And Bapat, our old good friend of the surgeon interventionist from Minneapolis. Yeah, we are ready. And my co-moderator, James Flaherty from Northwestern University. And let's begin the wrap-up interview.
Thank you.
Yeah.
We'll start with Samir. Samir, just give us an update on mitral valve catheter therapies in the United States. Where are things? Where are they going?
So I think we are right now facing two most important things. So for the repair side, we are now moving to the moderate mitral regurgitation with TEER. We are also investigating still the CLASP 2F trial to say that if we are going to have the different kind of TEER therapy, they are equal or not. And we are doing the EMPOWER trial. And in the EMPOWER trial, we are putting the carillon device for mild, moderate, or severe mitral regurgitation with patients with heart failure. So these are the three, I think, repair-related new trials ongoing in the United States. In terms of replacement, there are all trials are still feasibility trials or first-in-man trials. The Apollo may be randomized trials, but so far they're all non-randomized, single-arm trials. In Cleveland Clinic, we are doing TWIST, Cephia, and Tendyne. And of course, the Apollo is ongoing. So these are the trials that are currently ongoing in the United States. I don't know in terms of how you select the patients for each of these trials remains to be a challenge. That if you have the replacement and repair trials, how do you pick the patients? How do you follow them? And it's mostly related to the risk of the patient and anticoagulation at this particular point in time.
Thank you. Dr. Sung, I saw an earlier case using the Dragonfly device for TEER. Have you had experience with that, and how does that compare to the MitraClip procedure?
Actually, I don't have any experience about Dragonfly. It's China domestic devices. But I'm very impressive on the MitraClip design that Dr. Samir in his today's live demonstration case also shown when you have a aortic Haka. By using the MitraClip, you can have a positive nod to adjust the aortic Haka. So, but it seems that the Dragonfly might not have the same design. But I think all the TEER device also has its advantage and also disadvantage. For example, the Pascal with sensor spacer might be very helpful to treat the patient with functional MR, or even in a CAP2D trial, it also demonstrates very long listing MR reduction. So I don't have experience about Dragonfly, but I love the available device, the MitraClip, and also the Pascal.
Surgeons always say that the RFA like procedure TEER is not sufficient, not enough for the treating the MR. Yeah. But then how about the mix of the annuloplasty device and the TEER device? Would it be working or not?
I agree with you. I personally think that the annuloplasty devices, so by the way, MitraClip does produce septal, reduction in the anterior posterior dimension. So it does have some effect on annular function and annular dimension. The question is that whether you can put a carillon device or other annuloplasty devices. There are not that many annuloplasty devices currently available, at least in the United States in the trial. So this is a challenge. And I have few patients that we put MitraClip and then put carillon, but very, very few patients. So, and in Europe, There are some people who have done this combination, but again, it is not very clear that whether this is going to be in what order we should do it. In Empower trial, we allow the carillon first, followed by clip.
Okay.
So that is the design of the trial.
I think it will benefit certain group of patients. It's based on, if you think of surgical principle of not reduction in annulus is probably more important if it's a FMR. And I think stabilization of annulus will be critical if it's DMR. So I think we have to look at annuloplasty slightly differently as well. Just adding to Samir, there are two important US trials which I'm surprised he didn't address, is moderate risk trial. So primary MR and repair MR. And as a surgeon, we are of course anxiously waiting. One is an intermediate risk trial where it's going to go, and primary is all comers. And I think these trials have challenges in terms of recruitment as well at present, but at the same time the cadence is slowly picking up. So those are, in my mind, actually more important trials because the use of TIA procedures is ceiling. It has reached the ceiling in US. The growth is less at present. So we will see how these trials shape and what happens in
Do you
future.
think this is the right time for those trials, given going up against the gold standard, which is surgical repair?
So we had our own doubts, of course. We know that transcatheter treatment, at least those of us who have been involved for more than 15 years, have tremendous strengths in terms of safety and certain endpoints such as bleeding, hospital stay, etc. I think going to intermediate risk was sensible. Going to all comers is extremely risky because as there is a variation in mitral clip, there's a variation in mitral repair as well. So we are going to wait and watch now to see how this shapes up.
If somebody fails a mitral clip, can you surgically repair that, or is it only replacement at that point?
So we can remove certain mitral clips. There is a technique to remove it. In fact, at TVT, I recorded a case to show how it can be removed. In Barlow's or with patients who have got redundant leaflet tissue, you can still repair the leaflets. But in majority of the patients, you may not be able to because the repair is always based on adequate leaflet tissue. So, but there is a way to remove it without damaging, causing more damage to the leaflet.
So the one, I agree that I missed on that one, but it is a primary MR. So these are the people who are primary MR, young people,
Yeah.
and we are the third highest randomized people in the primary trial, all-comer trial. So there is a surgical buy-in from the CTSN and NIH to say that this is so we are randomizing patients. And I agree with you, even for an interventional cardiologist, it is a little bit of a challenge to say that a young, very repairable valve patient, that now we are going to put them, it is 65-year-old cutoff.
Yeah.
So 65 and older,
Yes.
any risk are randomized to clip versus
It's very ambitious.
very ambitious.
To go up
And
against surgery.
But I think the physiological thing, which is not probably discussed very well by the surgical colleagues who are involved in this trial, is no cardiopulmonary bypass and reduction in MR may be sufficient enough for survival benefit in the patient. So I think although with robotics and all we can repair the valve perfectly well, there is still an element of cardiopulmonary bypass and its effect. So we are going to see anxiously how the results shape in, and I hope they shape in favor of surgery.
but there is only death and valve replacement as the
MR.
endpoint, and nothing else. So this is and 2 plus MR.
Yeah,
So it is designed to help some ways surgical outcomes.
exactly.
Samir, you alluded to the Tendyne trial, and in a MAC is a terrible thing to deal with surgically. Do you foresee a device being able to handle MAC cases percutaneously or transapically?
We have done it, and again, it works. So Tendyne is a great valve for that purposes, but again, the ventricles are small. These are not dilated ventricles.
Yes.
And so when you apply the tension on the Tendyne, you create a lot of diastolic dysfunction in these patients. So the patients may not really sometimes they not feel very good because the ventricle is now impaired, because these are MAC patients typically have normal ventricles. So if your ventricle is dilated and if your LV function is a little bit impaired, then it's a different kind of a patient population. For Tendine with a high pressure, it's a little bit of a challenge. That's my sense. Again, we have very few patients that we have done. But M3, I missed that. So M3 makes now we can do M3 in the
In M3, you're putting an anchor for
anchor
a sapien valve.
Sapien valve, and then we are enrolling that too
MAC.
for the MAC also and without the MAC. So M3 is again another great valve for transcatheter valve replacement.
I think the MAC population is very heterogeneous, and MAC, like porcelain aorta in TAVR, is overcalled at present. So our center has the largest experience in MAC for anything really. So we divide them based on surgical risk and anatomical risk. And that's very important. If it's a surgical risk, then patient gets discussed onto transcatheter options. And it could vary from a balloon expandable sapien with or without lampoon, to a Tendine, to now Cephia as well as Intrepid are enrolling patients with MAC selectively. But if they are low surgical risk, then we look at MAC as a risk for surgical techniques. And if it is not, so then only we proceed with transcatheter treatments. And we have got a very good experience with surgical treatment as well.
Dr. Kang, do you want to move to talk about the tricuspid valve now?
Oh, shall we? It's time is so fast, and let's move to tricuspid. And now the tricuspid, we have heard a very good lecture from Dr. Vinayak. That my first question is that what's your perspective? That where would be the borderline between surgery and transcatheter treatment?
So
tricuspid?
we heard a really nice lecture from James. Honestly, surgery for tricuspid is more concomitant. That means if we are treating something left-sided or any other disease, we are more aggressive in correcting tricuspid now, especially now that we see a lot of patients come back and we don't have good options. So isolated tricuspid is currently limited to only select patients, and those come with infected endocarditis. Those select patients, the number is increasing slowly. The reason for that being, we now can optimize them. We have learned from transcatheter to optimize them with heart failure treatment, do right heart cath before, and do a selective, minimally invasive tricuspid repair or replacement. And I think this will improve at least our short term. I don't know about long term results, but at least short term results.
We talked earlier in the session that we're waiting too late for some of these tricuspids. Is that the surgical experience that
Yes.
if you operated earlier, maybe you'd have a better outcome and more options?
Absolutely. But the main hesitation is we don't get patients early. These patients are sitting in community cardiology or general practitioners, family physicians, even patient who has got severe TR, who is functionally well, patients are not referred to us for treatment, and maybe rightly so. So when we see these patients, they already have multiple other issues going on, including liver failure, and we have used different scores, but we still cannot get a good handle on what post-op outcomes going to be in these patients.
Yes, because the TI is really a volume-dependent situation. So from the very first beginning, the physician, the cardiology may treat it with only diuretics. Right. The patient can really feel better. So it's not really hard to convince patient that someday he would get RV failure and to encourage him to receive the procedure, to receive the surgical.
Dr. Song, have you had experience with the mitral clip or the tri-clip in the tricuspid space in your practice?
Yes. In the very early beginning, when tri-clip is not available, we use the mitral clip to do the tricuspid TIA procedure. But nowadays we have tri-clip, that dedicated device that is because the design of the steerable guide is quite really useful to do that. So we also encourage patient, if the patient have concomitant mitral and also tricuspid disease, especially for those with functional tricuspid disease and already dilated trabecular annulus, that we would discuss with patient. Maybe we can go for with the mitral and then tricuspid TIA procedure. In the past days, we use the mitral and to do the tricuspid and concomitantly, and nowadays we can use the TriGuide to do the mitral and also tricuspid simultaneously.
So it is approved now in.
It's approved to treat, yes, both devices have been approved to treat the mitral and also tricuspid procedure. No, not for both, but independently, separately. Mitral for mitral procedure, tricuspid for tricuspid procedure. But the guide is
because
the same.
in the United States, currently the guide is only in the triluminate trial.
Yeah.
Otherwise, we have to use the clockwise rotation and use the, like how you would use the mitral grid
Yes.
for the tricuspid.
Yeah.
So Samir, for tricuspid regurgitation, do you think it's a question of repair versus replace, or is it more nuanced than that?
I myself think that the leaflets are not designed for TEER kind of procedure. It's going to be a little tricky
Unless they're perfect.
Unless they are perfect, or unless you are treating it very early. So very severe tricuspid regurgitation, TEER is not a good, not going to work. And if you have very severe tricuspid regurgitation, then you should assess the RV function with pressure volume loops. I'm starting that. So to say that if you can replace the tricuspid valve, is the RV going to tolerate the pressure overload? Because it is more of a challenge than in mitral, because the RV function is difficult to judge, and it's a low pressure system. And all of a sudden, when you put a tricuspid valve, patients struggle. So this is an important part in the pre-evaluation that will come up in the near future.
So the difference is that when you put a valve in, you get rid of all or most of the TR versus when you repair, you're leaving some behind. Maybe that's
Or a lot
safer.
Or a lot behind.
Or too much.
So whether it really helps the patient is a question at that point. So, it's a very fine balance.
But I think this safety of these trials are critical, because I think if they lead to early intervention, that's the goal, I think, in these devices. Is if we demonstrate safety and efficacy, I think the indication should move towards earlier intervention. I think that's going to be really critical.
We talked a little about the Triluminate trial, and it did have a good safety profile, although the main outcome was quality of life. In the view of the panel, is that enough of an outcome to shoot for quality of life, or do we need mortality, hospitalization, harder endpoints?
I think we believe we probably need that. But I would like to echo Samir that is that because in patients with already severe RV failure, the tricuspid replacement might depress the RV function further. So why not we early do the tricuspid replacement comparing to the TEER procedure? Because the TEER procedure is much more complex than the tricuspid valve replacement. And also, the Vinayak also mentioned that comparing to the mitral valve replacement, the tricuspid replacement did not carry about LVOT obstruction and something else. It's only about the pacemaker, and a new device might probably counter that. So therefore, comparing to the complex TEER procedure, maybe the tricuspid intervention earlier when patient has severe MR, but at a very early stage, the RV can work even after the tricuspid replacement. We don't really need to wait until late.
Although, do you think there'll be challenges in getting approvals in our various countries to be able to use these devices earlier?
And I think the triluminate trial that you are asking, whether it is considered positive or negative, is a good question. Because if you look at the heart failure hospitalization, they are slightly higher in the patients with the clip. If you look at renal failure, is a little bit more in the clip. If you look at death, it is definitely not reduced, similar. So these are the very hard endpoints. And if you are not seeing any difference, even not statistically significant, but going slightly the other way, it is a little bit of a challenge. It is a little bit of disappointment, to be honest, because I participated in the trial and I worked very, very hard to make the trial positive. So it is, to me, it is a slight disappointment. Whether it is because the therapy is ineffective or we are not able to judge the tricuspid regurgitation valve, that the residual tricuspid regurgitation is just too much. My personal impression is that even though I treat them and I am very thrilled about it, we are left with a lot of tricuspid regurgitation.
71% were massive or torrential to start. So this is end-stage disease in a lot of patients.
But again, they're well selected. The gap is small, so it is not that
So
torrential.
I think the
They're
main-
anatomically good, but they're still
the other
advanced.
thing is the placebo effect, as patients knew they're undergoing intervention.
There was no sham arm in that
Sham
trial.
And I think that was important. But however, I think if you look at it differently, Harpoon, which was a transapical cord device, the trial was in low-risk patients. I think it would have been critical if this trial was done in, even asymptomatic severe TRs. The only problem is how do you show the benefit in this patient? And on tricuspid, as I said in my talk, it is hard to judge objective benefit at present because whether it's survival, quality of life, or could there be a better objective measure, we really don't know the answer at present.
Well, Dr. Kang, would you like to wrap up the session? I think we've
Yeah.
learned a lot from our experts. And
Would you wrap up?
Sure.
Before I begin.
well, we've heard a lot today through the sessions and through our experts on the current state of mitral and tricuspid transcatheter therapy. And although there's a lot of excitement, there's a lot left to learn. And hopefully with their efforts and others, we'll have more to say about this next year.
Thank you.
Thank you.
It was
Thank
a great
you.
session.
Thank you.
Thank you.